bubble flows is when all gas move in the same direction due to a difference in the total pressure. But in air movement past respiratory surface, is it the directions of the movement of the O2 and CO2 difference? Respiratory surface, not other than alveoli and also tissue and blood vessels, right? Maybe
It's referred to the I directly copy from the slides. It's slide number 5.
okay. Okay, the respiratory surface. Okay. If let's say we are talking about the okay, the easiest way is like from the atmosphere to the to the to your larynx of your pharynx. Okay, so the air movement essentially is one directions. Okay, in that sense, okay, the oxygens and also the carbon dioxide actually also moving in the same direction, which is towards your from the atmosphere to your larynx. Okay, but somehow in the, if let's say the different directions could be happens in the cells and also between cell and blood vessel and also in your alveoli and also the blood vessel. That will be a difference. That involves the diffusion, but not in the blood flows anymore. Okay, so when you're breathing in or breathing out, actually when it goes through your nasal, okay, the passage ratios of nasal, everything goes in the blood flow one way. Okay, that's containing some of the carbon dioxide as well as the oxygen. The air that you're breathing in and breathing out, no matter what, they will contain oxygen, nitrogen, as well as the carbon dioxide. All right. So the next question, we learned that intra-pleural pressure is generated by the elasticities of the lung and thoracic wall. So when there is a more lung elasticity, okay, when there's more lung elasticity, we create more negative intra-pleural pressure and thus equalize the increased elasticity. Okay, so again, okay, when there's a less surfactants, okay, elasticity will be increased. Elasticity increase, okay, so the intrapleural pressure will be, the space we're getting, yes, increase, all right. More negative, yes, it will become more negative, and thus equalize the increased elasticity. Create more negative intrapleural pressure, and thus equalize the increased elasticity. Yes, there will be happen. No matter, there will have one point where the lung cannot be totally collapsed. That's the pressure that equalizes between the pleural and also the alveoli. In case you don't have a surfactants, no matter what, they will have something. They have a balance in between the pressure in the intrapleural as well as in your alveoli, okay, and involving your chest wall, the elasticities of the chest wall. All this one created. Okay, even though there's a less surfactant, yes, the intrapleural pressure will getting more decreased, but at one point, okay, the lung will not be collapsed because the pressures is equalized. Yes. All right. Okay. So next, we continue with the next lectures. All right. So actually, I proceed with the lung volume and capacity because once you learn this, and during the next phase, during the next lecture, it's all about the transporting. Oxygen transporting and also the carbon dioxide transporting. Then you will, because that two actually should be linked together. Okay, it cannot be separated. Like today, we learned about the oxygen, and then the next day we learn about the lung volume, and then followed by the carbon dioxide transport, which is separated, cannot be linked anymore. So I will continue with the I will continue with the lung volume. Okay, so it is slightly changed in the your lectures titles. Yeah. Okay. So okay, lungs volume and capacities, and also the that space. Okay. Excuse me. Okay, so in these lectures, you guys should be able to know what is the tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volumes. And there is a capacities as well. Means that you will have a volume to learn, you have the capacities to learn. Volume only referring to one, one, one unit. Okay, when we talk about the capacities, it's in more than one unit. Okay, means that you need to have what A plus B to get the capacity. But for volumes, you only need to have A or B or C. That's different between the volume and capacities. Okay, and the anatomical dead space, alveolar dead space, and also the total dead space, also known as the physiological dead space. And last but not least, the pulmonary function test. Okay, so as an introductions, okay.
I'm sorry,
Yeah,
doctor.
yes.
Based on the timetable,
Mm.
we are learning RS11 gas exchange, right? RS10 is an SCL at tomorrow,
Yes, correct,
right?
correct. Yeah, but we don't
Yeah.
have the SCL during the this moment.
Oh, okay,
Yeah,
okay.
that's why I bring the lung volumes and capacity forward. But in case when there is a physical lectures, right? Yes, this should be in the SCL. Means that you guys will learn. I mean, will not have a lectures, but guys have a different activities to learn these lung volumes and capacities. All right, yeah.
Also, the tomorrow
Mm.
SCL is cancelled, is it?
Um, it's not
Oh,
cancer, but I mean, go with the gas exchange.
oh, okay, okay,
All right,
okay.
everything will be the same, just that I changed the titles of the lecture.
Okay, okay.
All
I
right,
got it. Thank you.
okay, welcome.
Thank you,
Okay,
doctor.
okay, welcome. So in average, okay, the maximum air that the lung can be holds is about 5.7 in male and then 4.2 liters by the females. But somehow this volume can be changed, yeah, due to the age curve or any diseases curve. Okay, so this lung volume can be determined by the spectral, sorry, spirometer. So in your ECE, you guys will learn about what is a spirometer lah, how to use it, and also the peak flow meters as well. All right. So typical under normal breathing or quiet breathing, there's 500 mils of the air actually is going in, and also 500 mils of the air actually is going out. Okay, breathe in and breathe out is the same volume, except you are forced yourself to increase to inspire more or exhale even more. Okay, so during a maximum expiration, the lung volume can be decreased to 1,200 mils in the female in the male. Okay, and lung can never be completely deflated. Okay, it means that your lung cannot be totally collapsed. Okay, no matter what, there's still have something. There's a force. Okay, that is a that withhold the pressure in order to have a total total deflations of your lung, except there's a pneumothorax. Okay, when there is an atmospheric pressure, it's the same as your lung. That will be a different story. Okay, okay. So your total lung capacity at the maximum inflation, okay, is about 5,700 mils. Okay, when in your normal breathing, okay, when you're breathing in, that's about 2,700 mils of the air. When you exhale, it's about 2,200. So means that if let's say you minus, then you will get 500. 500 moving in, 500 moving out. Okay, where this is a minimum lung volumes. Okay, residual volumes at the maximum deflation. You try to exhale as much as possible, but still there is a remainings of the volume. That's we call it as a residual volume. This is residual volume. No matter what, you cannot. Okay, no matter what you can do, how you compress your lungs, there's still some air inside your alveoli. That's your residual volume. Okay, so take a look at the lung volume. Okay, so lung volumes can be divided into 4 units. We have the tidal volumes, expiratory reserve volumes, inspiratory reserve volumes, and also the residual volumes. Alright, so we take a look what is a tidal volume first. Tidal volume is normal breathing. Okay, the volumes of the air that moving in and moving out during a normal breathing or unforced breathing. So you can see this is the tidal volume, VT. Okay, breathing in, breathing out. This volume, sorry. This volume, okay, is the tidal volume. That's 500 mils. Inspiratory reserve volume. This reserve volume, okay, is already mentioned. Inspiratory, inhale, but there is a reserve volume. When you are trying to put some effort to inhale more, then this is the inspiratory reserve volume, IRV. Okay, it's an extra volume of the air that able to moving into your lungs after a normal inspiration. It means that, okay, this is a normal inspiration range, right? You exhale normally, inhale normally. Once after you inhale normally, then you force yourself to inhale more. That will be the inspiratory reserve volume. All right. While expiratory reserve volume, exhaling, okay, after you exhale normally, then you force yourself to exhale even more. Okay, exhale even more. So that will be the ERV. Okay, always need to mention this after a normal expiration or after a normal inspiration. Okay, if let's say you need to give some definition, this one is important. Normal inspiration. Okay, and also the normal inspiration. You will get this IRV and then ERV. So the volume here, the numbers is not important. The number is not important here. Okay, so no need purposely to memorize all those. ERV is how much lah, IRV is how much lah. No need. All right. So residual volume, as I mentioned earlier, no matter how much you compress the lung, okay, no matter how forcefully you exhale, they still have some air inside. That will be your residual volume. This is the residual volumes. All right. Okay. So which lung volumes can be measured using a spirometer? Okay. So this one you have to try to think about it. There is some value that can be measured directly and also some value indirectly. So what is it directly? What is it indirectly? Try to figure it out. What are the volume that can be measured by the spirometer directly, and what are the value, okay, or lung volumes that can be measured indirectly by the spirometer? Okay, next we'll take a look at the lung capacities. There's combinations of 2 or more lungs volume. First, we started with the FRC, the functional residual capacity. So where is the FRC? So this one is the FRC. FRC is about ERV, expiratory reserve volume plus with the residual volume. Okay, so it means that after you exhale normally, then you forcefully exhale, Okay, you forcefully exhale until a moment, a point that where you cannot exhale anymore. Okay, plus with the residual volume. Of course, like residual volume is standard, means that we hardly to measure it. I'm sorry, we cannot measure the residual volume. We only can measure after, assume it is 1.2 liters. All right, so FRC is 1.2 liter plus your ERV. Next is the IC, inspiratory capacity. This is your IC. IC is combinations of the tidal volume with your inspiratory reserve volume. So it means that after you exhale, okay, after normal exhale, then you try to inhale forcefully. Okay, you inhale forcefully, inhale, then you will get this volume, this capacity, tidal volume, including your inspiratory reserve volume. If let's say in the essay you write it um, uh, uh, IRV, let's say I ask you to define IRV, inspiratory reserve volume, then you mistakenly thought that the value should be started from here after you exhale, and then you forcefully inhale. Okay, that's not the value for the IRV. Yeah? IRV is from here. Okay, after normal breathing, then you force yourself to inhale. Okay, then you will get the IRV. But for the IC, inspiratory capacity, you need to inhale forcefully after exhale normally. Okay, that will be the difference. Okay, next is the vital capacity. Where is the vital capacity? VC. Okay, VC is here. Okay, it's the tidal volume plus your IRV plus your ERV. Okay, it's the maximum volume, okay, of the air that can be expelled by the lung by a forcefully effort following by a maximum inspiration. It means that after exhale normally, you inhale forcefully and then exhale forcefully, then what you get is vital capacity. All right. Next, it is frequently measured clinically as an index of the pulmonary function for this TLC. Sorry. Okay, for the vital capacity. Okay, so it gives a useful information about the strength of the respiratory muscle and all the other aspects of the pulmonary function. Means that when you inhale forcefully and then exhale forcefully, it will definitely give some indications about your pulmonary function as well as your respiratory muscle. The fractions of the VC expired during the first second of the forced expiration give additional information. The FEV1, yes, this value is very, very important. You will learn this in the in your ECE, okay, maybe in my few more lectures, then you will learn about the FEV1. Why so important of the FEV1? Where is the FEV1? Means that FEV1 is like you inhale forcefully, before you exhale forcefully, try your effort to exhale it as fast as possible. Within the first second, we measured that. We measured this FEV1. That's the first second of the forced expiration. Okay, it's a very important value. Okay, so next is the total lung capacity, TLC. So this one is a TLC, including the vital capacity, the ERV, IRV, and also your residual volume. Let's say only the vital capacity, only the tidal volume, ERV, and IRV, that will be your vital capacity. That will be your that will be your vital capacity. without the residual volume. If let's say including the residual volume, that will be your total lung capacity. Okay, all this capacity and lung volumes is important. You guys should remember the definition. Okay, and should be able to how to define it. Okay. All right. Again, this one to show you the diagrams of the residual volume. Where is the ERV, tidal volumes, IRV, vital capacity, IC. Okay, all this. Okay. All right. So next is dead space. Okay, we have a few dead spaces here. Represent the volume of the ventilated air that does not participate in the gas exchange. Okay, then you question, hey, how come there is no air that participates in the gas exchange? Yes, there is in your nasal. Okay, when you're inhaling in the larynx, in your pharynx, they're still containing of the air, but this air does not involve in the gas exchange. Means that this area is a dead space. But what kind of dead space is that? There are few. Then we learned about it. Okay, so gas exchange occur only in the terminal portions of the area. Okay, the alveoli. The gas that occupied the rest of the respiratory system is not available for the gas exchange at all. So the alveolar ventilation is less than the pulmonary ventilation because of the dead space. In the pulmonary ventilation is about 500 mils, right? Breathe in and breathe out about 500 mils. But then this 500 mils is not represent how much of, is not representing the that's the volumes of exchange between the gas that come from the blood vessel to your alveoli. No, totally different. Take a look at this. Okay, in the alveoli air, okay, there's an area, okay, that space about 150 mil. Okay, when you're breathing out, okay, you're breathing out about 500 mils. Okay, so 350 with the 150 consistent. You're also having another new, I mean, there's new air that you haven't used. That this one is an old air. Okay, so that would be, I mean, this 150 is located at your dead space. Okay, so we have the anatomical dead space. It's a volume that occupied the space from the external nares to the terminal bronchioles. This space, okay, this dead space does not involve in the gas exchange at all. This is what we call it as a conducting zone of the airway. Okay, so the normal values is 150 mils in both of the genitals. While in your alveolar dead space, okay, we assume that all the atmospheric air entering the alveoli participate in the exchange with the pulmonary blood. Match between the air and also the blood is not always perfect because not all alveoli are equal ventilated with air and perfused with the blood. It means that, for example, you have 100 mils of the air that moving that reach the alveoli, but not 100 mils of the air actually having a gas exchange with the blood vessel, with the pulmonary blood. No, because some of the air, I mean, some of the alveoli is not ventilated equally and also not perfused with the blood. Means that there is no blood vessel. Okay, why does it can happen? I will show you later. All right. So any ventilated alveoli that do not participate in the gas exchange with the blood because they are inadequately perfused. Okay, perfusions is very important. If let's say there is not enough of the perfusions, then that's, I mean, that place, okay, we call it as alveoli dead space. Okay, healthy alveoli dead space are quite small and of little in importance. Otherwise, it's not significant. I mean, in terms of the clinical, it's not that important if let's say you are healthy lah. But for those people is not healthy, their alveoli dead space is getting getting increased. Then if it can indicate some several types of the pulmonary disease. All right. Okay. Take a look at the alveolar dead space. First, we have the hydrostatic pressure failure. If let's say that the hydrostatic pressure is failed, okay, means that the blood actually is not moving equally. Okay, some of the blood have stopped because of the hydrostatic pressure. Then the perfusion is less. Okay, B is a normal. Okay, C there is an embolus. That is a stuck. Okay, that is a stuck in the blood vessel, pulmonary blood. Okay, blood vessel is stuck because of the embolus. So the perfusion is failed. And D, take a look, emphysema, no blood vessel at all at the alveoli. Okay, so this one is totally is a dead space, alveolar dead space. E, pre-capillary constriction. So there is a constriction on the capillary state and the pre-capillary state, something like an embolism as well. So when that is a constriction, less blood flow. Thus, the perfusion is not enough. So let's say 100 is moving in, even though there is a blood vessel is going through, maybe only half of it able to perfuse. That's the another 50 considered as a dead space law. All right, so not 100, you will get 100. No, it won't. All right. Okay, next is the physiological dead space, also known as a total dead space. It's the volumes of the gas that is not equilibrating with the blood. We call it as a wasted ventilation or irrespective of the site where the gas is. So it's a totals of the anatomic as well as the alveolar dead space. However, okay, in health, okay, healthy person, two dead spaces are identical, anatomical and physiological, because alveolar dead space is too little or not significant contribute to the volume at all. Okay, but somehow the disease, okay, the physiological dead space may be increased. Okay, so there is no exchange between the gas in some of the alveoli and also the blood, and some of the alveoli may be over ventilated. Yeah, it can be over and ventilated or under ventilated. So the volumes of the gas in the non-perfused alveoli and any volumes of the air in the alveoli in excess of that necessary to the arterialize the blood in the alveolar capillary is part of the dead space gas volume. Okay, it means that the one that not perfused, the volume of the gas is not perfused, and there's too much air in the alveoli that needed to perfuse to the artery. I mean, to perfuse to the pulmonary blood. For example, you inhale 100. There is 150, but basically you only need to have 100 to be perfused. So that 50, the extra 50, the extra 50 is part of the dead space gas volume. All right, either it's under ventilated or exceed the ventilation. Okay, so the anatomical dead space is increased when somebody underwater try to breathe air through a long narrow tubing. Why? Because the long narrow tubing also considered as an anatomy. So you mean that you are extending, you are increase the anatomical dead space. Okay, even though that the tube is not part of our body, but when you are using that, actually it's like linking to your body. Okay, means that it will become part of your dead space as well. So what's so important about dead space? Increase in dead space volume will effectively decrease the alveolar ventilations. So we don't want to have that actually. Okay. So take a look. This is a physiological dead space. Overall, means that total anatomical dead space as well as your alveolar dead space. Total up, then you will get physiological dead space. Okay, so again, to show you what is a total anatomical dead space, alveolar dead space, and what is a physiological dead space. See, you can see this is the tube. We also can call it as an apparatus dead space. Okay, so how much is actually able to be ventilated? This is the volume, alveolar ventilation. This is the volume. You breathing in so much of the air, you only use this amount of the air effectively to exchange with the pulmonary blood. All right. Okay. So again, this to show you some of the ventilation process that not. I mean, this one it should be the ideal one. Okay. But somehow when there is a shunt, okay, means that for example anatomical shunt without the alveoli, okay, this is shunting. We will learn this later, but somehow we are more focused on the physiological dead space. All right. So what is the ventilation rate? Ventilation rate is totally okay. Same concept as the uh, 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 sorry, it's totally same as the your cardiac output. Okay, let's take a look. Respiratory minute ventilation is expressed as the minute ventilation tidal volume times with the breath per minute. That is a ventilation rate. But in your cardiac output, if you still remember, equivalents to heart rate times stroke volume. Now you can see the same thing here. Stroke volume is how much of the blood that moving in and out from the moving out from the ventricle for ejection, similar to the tidal volume, right? Breath per minute, similar as a heart rate. So your minute ventilation actually similar as a cardiac output. If let's say you forget about the cardiac output, then and only remember the minute ventilation, then you can use the same formula. Okay, it's the same. Okay, about 6 liters per minute for the minute ventilation. So this is the air that entering the lung each minute, similar to the cardiac one output. Volumes of the blood that entering the pump up from the lungs. Okay, the pump up from the pump up from the heart per minute. Okay, so it depends on the respiratory rate as well as the tidal volume. Means that it affected by the heart rate. Okay, it's similar to your cardiac output, affected by your heart rate and stroke volume. But in the minute ventilation, it affected by the respiratory rate and also the tidal volume. So the alveolar ventilation is you need to minus the dead space, okay, and times with your respiratory rate. So this is what you got, 4.2 liter per minute. So this is the effects of the variation in the respiratory rate and that on the alveolar ventilation. For example, you breathe, your respiratory rate is 30 per minute, and this one is a 10 per minute. You will get 6 liter, okay, minute volume. And what you got in the alveolar ventilation is 4.2 liter. But somehow in exercise, your respiratory rate is increased. But remember, your tidal volume will be reduced because it's a short breathing, right? When you are having exercise, you're having a very fast respiratory rate, but what you consume, okay, the tidal volume will be getting less, okay? So what will happen is that your alveolar ventilation will getting less. Okay? Okay. So because of the dead space, the rapid shallow respiration produce much less alveolar ventilation than a slow deep respiration at the same minute volume. Next is the respiratory function test. So you know all these are lung capacity, lung volumes, and also the dead space. So now you have to know what are the respiratory function tests. What is so important? Okay. For example, for the lung volumes and capacity, we are using the spirometer. Okay. So a reduction in all the subdivisions of the lung volume is characterized as a restrictive lung disease. So those diseases in which the lung expansion is limited by a factor such as increased elastic recoil. So if let's say you increase the elastic recoil, the compliance will be reduced. You hardly to breathe it in, you hardly to breathe in, but easily to breathe out. Okay, means that your lung volume will be reduced. Okay, all this will give you with the respiratory function test. It will give you some hint. Okay, it's not a diagnose tools, okay, but it's actually it's help you to give you more information. What are the what types of the diseases, respiratory illness having by these patients. All right. So there is a series measurements of the vital capacity may be useful to judge the prognosis of the such patient. So it also can be used as a prognosis, whether how bad is a patient or how good is the ill of the disease. Okay, so residual volume is normally less than 30% of the total lung capacity, although it will increase to a 50% in the old age, because in old age your lung elasticity will getting I mean, the lung elasticity getting increased, more becomes stiff, okay? So residual volume is getting increased, okay? So an increase in the residual volume is a characteristic of the hyperinflation of the lung. For example, in the bronchial asthma or in the emphysema, okay? Next, forced expiration. In the forced expiration, check the timed vital capacity. As I mentioned earlier, the air
Can anyone hear doctor speaking?
No.
Or does anyone does not hear doctor speaking?
Yeah.
Yes, I know.
All right. Okay, I'm so sorry. Is it disconnected just now?
Yes, doctor.
It's
Yes, doctor.
Where we stop just now? Where you guys cannot catch, huh?
Um, if I'm not mistaken, it's about the forced respiratory volume in 1 second.
Where is it? Hello, hello. You guys ever still can hear me?
Yes, doctor.
Yeah. Okay. Where we stop just now, before we get disconnected,
This slide, doctor. On this slide we done here.
Sorry.
On this slide, first aspiration is already disconnected.
I can't really hear you. Okay. I just want to confirm. Do you guys can hear me clearly and very smooth,
yes, doctor.
or actually
Yes,
it's lagging?
doctor.
All right. Okay, that's good. Okay, where we stop? Is it this slide? The slide what? Where I mean, forced expiration. Is it?
Yeah.
Or the previous slide, where we stop. All right, okay. So I continue here. If let's say you guys having any problems or myself having a problem, because this one I can hear something, a signal. That's why I stopped, and then I found out that there is a disconnection. All right. Okay. So I continue. Sorry. Pause expiration. Okay. So um, in the force expiration, that is one thing that is so important about this, the FEV1, the force expiratory volume in the first second. So before you get the FEV1, you must know how to get it. It means that you need to have a force inspiration, inhale as much as forcefully, inhale forcefully, and then exhale forcefully. But during you exhaling, you need to exhale as fast as possible. All right. Then from the first second you exhale forcefully, that's the volume that we take. Okay, that volume is very important. So 75 to 80% of the force vital capacity is expelled smoothly and rapidly in the first second, and the remaining 20 to 30 take about further 2 to 3 seconds in the normal subject. So it means that in the normal healthy person, the FEV1 should be around 75 to 80% or 0.75 to 0.8. All right. So the FEV1 is reduced in the obstructive airway disease, for example, bronchial asthma, chronic bronchitis, and also emphysema, because of increased airway resistance. Because there is a resistance increase, that you are hardly to expel your air out. All right. So the volume here, the percent here, we're getting decreased. That gives you indication that that is a obstructive airway disease. Also reduced in the restrictive lung disease due to the overall reductions in the lung volume. So in the restrictive, what is a restrictive and what is obstructive? Obstructive is something obstruct your airway, but in the restrictive, it means that your lungs having a fibrosis that cannot be expand and contract. That is a restrictive. Okay. All right. So in both cases, FEV1 will reduce in obstructive, will also reduce in the restrictive. Okay. But somehow, take a look at this FEV1 ratio, FVC. This able to help you to differentiate which one is obstructive, which one is restrictive. Previous slide, you know that FEV1 reduced in both obstructive and also restrictive. But now we wanted to identify you are having obstructive or actually restrictive by this ratio. Okay, so obstructive airway disease, both FEV1 and FVC reduce, but reduction in FEV1 is greater, result in the low FEV1 and FVC percent. While in the restrictive airway, the FEV1 and FVC are reduced proportionately and the normal ratio is preserved. It means that in order for us to differentiate obstructive and restrictive, in obstructive, the FEV1 over FVC ratio will be reduced. But in the restrictive airway, the FEV1 over FVC ratio should be normal. Now you can see a difference. Why is normal? First, FEV1 in the obstructive disease is so much lower than the FVC. Means that lower means that, for example, this one is a value only one, but this one value is maybe is 5. So what you get is 0.2. But somehow in the restrictive area, what you get is FVC1 and FVC both is reduced, but proportionally. Means that, all right, normal is like 10 over 10 over 4, for example, example only. But then the reduce proportionally, I reduce 2. I also reduce 2. It's something like this. So the value, I mean, FEV1 and FVC ratio still considered as a normal in the restrictive area. So always remember, for you to differentiate the obstructive and restrictive, you need to use this ratio. If only this ratio give, if let's say only FEV1, then it only can tell you is a obstructive and also maybe restrictive. Okay, yeah? Remember this ratio is very, very important. In your clinical setting, this ratio is so much important. All right? Okay, so now you can see in normal is about this. You will get 83. FEV1 is 3.3, FVC is 4.0. But in obstructive, okay, FEV1 is 1, FVC is 2. Both is reduced, yes, both is reduced, but FEV1 is reduced a lot comparing with the FVC. When you get it, this is why you get it. Okay, the ratio. In the restrictive, because both FEV1 and FVC reduce proportionally, okay, what you get is still you will get a normal ratio. Okay, means that first you determine FEV1. If let's say FEV1 is normal, then it's normal. If let's say FEV1 is abnormal, either this obstructive or either this restrictive, then in order for you to differentiate these two, then you divide by FVC. If FVC is low, then is this obstructive. If FVC, this ratio is normal, then is restrictive. All right. Okay. Next is a peak expiratory flow rate. So it's the fastest flow rate over the 10 milliseconds at the beginning of the maximal expiration after a full inspiration. So this, to show you, this is a peak expiratory flow meter. You can have it during the ECG. So it is very easy to use and particular value in the serial assessment of the airway obstruction. Just look at, is there any obstructions of the airways or not? But it cannot tell you whether it's obstructive or restrictive. Yeah. Okay. Next is a maximum voluntary ventilation, MVV. It's a volumes of the air expired per minute when the subject breathes as rapidly, as deeply as he can. Okay, so the gas collected over a period of 50 seconds when the subject is ventilating maximally, and the value expressed in the liter per minute. So normally it's 125 to 177 liter per minute. So this volumes is correlated well with the FEV1. Okay, so of course, why we only can have a short only can collect within 15 seconds, because if let's say you keep having this kind of breathing, then you will get dizziness and then you will get pass out because you are lacking of the carbon dioxide. Why I'm saying lacking of the carbon dioxide? It's related back to your pH again. Okay, so you will learn more about this in the hyperbaric and also hypoxia. Okay, remember, when you are hyperventilation for a very long period, you will get dizziness, or maybe you will get fade and dark. Okay. Okay. Next is the forced expiratory time (FET). Normal people can empty their chest from full inspiration in 4 seconds or even less. So prolonged, it indicates either it's obstruction and reductions in the FEV1 and FVC. Okay. Next, test of the gas exchange, arterial blood gases. So this is what we wanted to know in your arterial blood gas, whether it's saturated with the carbon dioxide or saturated with the oxygen, and also with the pH. So pH always correlated with the carbon dioxide as well as your oxygen. Okay, so this ABG can be used to determine these three things. Okay, so in clinical, this ABG is very important, and you have to know on how to analyze the ABG. All right. Okay, so in clinical medicine, the commonest cause of the arterial hypoxemia means that low partial pressures of oxygen, it uneven distributions of the ventilation and perfusion due to the airway obstruction. You have enough of the air that moving in, but the perfusion is less. Or maybe perfusion is okay, but the ventilation is being obstructed. Okay, then it will cause you to have a different partial pressures of oxygen and also the partial pressures of the carbon dioxide, and eventually the pH level will be changed. So in practice, the measures of both arterial partial pressure oxygen and partial pressures of the carbon dioxide provide a very useful guide to manage a patient in the respiratory failure, such as in the patients of having a COVID-19. Yes, for those COVID-19 patient, once they're in the ICU, their ABG gas, okay, their ABG always been monitored. They wanted to know how much is the partial pressures of oxygen and how much of the partial pressures of the carbon dioxide. Because of their ventilation rate is obstructed, or perfusion rate is obstructed. There is too much of the mucus produced in their lungs that prevent them from breathe or ventilate normally, okay, or perfuse normally. All right. So what are the tests for the mechanic of the breathing? The measurement of the lung compliance and also the measurements of the airway resistance. For example, the pulmonary function test. We have all these. For example, FEV, FVC. We determine the FVC, FEV1, okay, FEF, the ratio. The most important are these: FVC, FEV1, FEV1 over FVC. Once these are having a changes, then it will give you some indication whether it's obstructive or it's a restrictive. All right. So we end the these lectures. Okay. All right. So if you have any question, you can just ask, or you can post in the chat box. Okay. So now I saw that few questions about the forced expiration. Okay. Okay. All right. It's not a question. Sorry. All right. So yeah. So I'll open for the questions. If you have any question, you can just post it in the chat box, or you can just ask directly. So for these lectures, what's so important is, first you have to know the lung volumes and lung capacity. Okay, the lungs volume and lung capacity. All this you have to know their definition. if let's say you don't know the definition, then you are hardly to understand the rest of the slide. Okay, next, after you know all this kind of thing, the lung capacity and lung volume and also the dead space, yes, dead space is the next. Dead space will be the anatomical dead space, physiological dead space, alveolar dead space. Is three. Okay, the anatomical dead space is very simple, lor. Okay, from your nasal up to the terminal bronchioles. Okay, while the physiological dead space is total up. Okay, and the alveolar dead space is at the alveoli, where there is no, I mean, the portions of the air or the volumes of the air that does not participate in the perfusion. That will be your alveolar dead space. Okay, that's the questions. When anatomical dead space increase, alveolar ventilation decrease. Okay, dead space are anatomical dead space. Anatomical dead space increase, alveolar ventilation decrease. Is there any important to decrease alveolar ventilation? Okay, for the first, yes, anatomical dead space increase. The alveolar anatomical dead space increase. Okay, not necessary here. If let's say your anatomical dead space increase, but the volume of the air when we use apparatus, okay. Is there any important to decrease the alveolar ventilation? No, I mean the alveolar ventilation have to be normal as possible. If let's say your alveolar ventilation is reduced, okay, your perfusion is reduced. Your perfusion is reduced. What will happen is that some of the tissue or cells or organ may not get enough of the oxygens. Yes, it's detrimental. Yeah. So alveolar, we are not trying to decrease the alveolar ventilation. Usually, that's why what in the lecture, what I mentioned earlier is alveolar ventilation, the alveolar dead space is very tiny. So it won't affect your alveolar ventilations. All right. So yep. So if let's say you decrease the alveolar ventilation, perfusion reduce, definitely will reduce, and yeah, you may have a hypoxia in that case. All right. Okay. So next is the after the dead space, then you have to know the ventilation rate. Yeah, the ventilation rate is more or less the same like your cardiac output. As long as you remember one of it, if you remember the cardiac output formula, then you will remember the ventilation rate because it's the same. Ventilation rate is okay. The minute ventilation equivalents to tidal volume. Tidal volume is similar as a stroke volume in your cardiac, and a breath per minute similar to your beats per minute. One is the respiratory rate, while another one is your heartbeat. Yeah. Okay. All right. So that will be your ventilation rate. And okay, respiratory function test. Okay, because now you saw there are few tests here. Okay, there are few tests here. What's so important about the test? I list out to you guys and I emphasize for you guys what are so important. I mean, which one actually is important? The lung volumes and capacity is important. Okay, because from the lungs volume and capacity, you will know the tidal volumes. Okay, the total lung capacities. Okay, the vital capacity, all this. Okay, in the forced expiration, Okay, in the forced expiration, you will get the value, the FEV1. Okay, now you have to think back how to get the FEV1. Yeah, that is an OSCE station. Yeah, okay. Frankly, to tell you, there's one OSCE station to measure the FEV1 to confirm the patient having a restrictive or obstructive, or actually is normal pulmonary function test. Yeah, how we're going to do that? We ask the student, okay, we give you this machine. So this machine able to help you to get the FEV1, help you to get the FVC. But you must know how to get the FEV1 and how to get the FVC. You must instruct the patient. First, you have to normal breathing, and then you have to after that, after the patient exhale normally, then you have to ask the patient inhale forcefully, okay, and then exhale forcefully and as fast as possible. Then you will get the FEV1. How about the FVC? How to get the FVC? Everything means that you have to know how to get this value in order to instruct the patient. The value will give you automatically from the machine. So you just click, get the value, and then you do the calculation. Then you will know either the patient having a actually is normal and healthy, or actually is restrictive or obstructive. All right. Okay. Peak flow. This one is important as well because it measures the vital capacity. It measures the whether it's having a obstructions or not in your airway. All right. So this one is kind of a bit not really seated. Okay. The maximum voluntary ventilation, not that frequent lah. Because it's because we already have a FEV1. Yeah, we have the FEV1. And forced expiratory times. And this one also not that important as well. Okay. And also the ABG. Yes, the ABG is very, very, very important. I think the next lecturers, Dr. Taufik will discuss more with you guys about the ABG, or even in the pathology. You will learn more about the ABG. All right. Okay. So, is there any other questions before we end the lectures? If none, or let's say, for example, right now you don't have it, but once you do the revision, or you find out that is a question, then you can just post it in the team. I will help you to answer. All right. And of course, I will give you some question as well, similar like in the previous lecture. I make it in the Google form, so try to answer it. Okay. So okay, if none, Yanbin, please get me the attendance after this. I'll post it in the Teams later. All right. Okay, so